Yes, my question is 25-year-old primey presented with difficulty in breathing, phonation, hypotension, and seizures after a bolus dose of local anesthetic drug given for labor epidural analgesia, sir. The symptoms of dyspnea, hypotension, and seizures pointing towards local anesthetic systemic toxicity, sir. And the question is how do we manage it? Management of local anesthetic systemic toxicity focused on ABC approach, sir, airway, breathing, and circulation. Airway management, circulatory support, and reduction of systemic side effects, including the seizure management. Uh, ACLS and prompt administration of the lipid emulsions. So initially, we have to stop injecting the local anesthetics and then call for help. And we have to position the patient with the left uterine displacement and to administer 100% of oxygen to maintain maternal oxygenation. If required, to use positive pressure ventilation if necessary. Tracheal intubation will facilitate support of ventilation and help protect the airway, but we should not delay the administration of O2 to intubate trachea. And then we have to support the maternal blood pressures with fluids and vasopressors. For seizure control, we can use benzodiazepine, midazolam to prevent injury and acidosis. And we can consider 20% intravenous lipid emulsion, sir. Initially, we can give the bolus dose of 1.5 ml per kg over 2 to 3 minutes and an infusion of 0.25 ml per kg per minute. And we have to reassess the cardiovascular stability. If the patient is not improving, we can repeat the bolus of 1.5 ml per kg, and we can double the infusion to 0.5 ml per kg per minute. And then the recommended maximum dose of lipid emulsion is 12 mg per kg. And we can monitor the maternal vital signs and fetal heart rate, and simultaneously we can prepare for emergency delivery. To consider delivery the infant if mother is not resuscitated within several minutes, because this may facilitate the successful resuscitation of the mother. And we also can alert the nearest facility capable for cardiopulmonary bypass if it is not available in the center.
So your diagnosis only LAST.
Yes, it could be also anaphylactic reactions.
Anaphylactic to local anesthetic
To local
agents?
anesthetics.
Very, very rare.
Yes.
Any other diagnosis? Can anyone think of any other diagnosis?
Total spinal inhibition.
Total spinal is another important diagnosis. Okay. So how to
Okay.
differentiate between total spinal and LAST?
Sir, in total spinal, we don't expect convulsions, sir, seizures.
Why? If the patient goes into hypoxia, can it not be producing a seizure?
The onset of time, sir.
Hmm.
The total spinal anesthesia, it is immediate, but lost, it can be manifest first seen CVS symptoms, then CNS.
Yeah, so LAST will have first a CNS symptom followed by serious symptoms.
Since there's a
Any
history
other
of
method of diagnosing whether it is total spinal or LAST?
there will be bradycardia.
Bradycardia. What
Bradycardia.
is the
Yes,
difference in bradycardia in total spinal and LAST?
In last, there might be initially hypertension and tachycardia followed by hypotension and brady, sir. In total spinal, we'll have bradycardia and hypotension, sir.
Okay. More than that, the bradycardia in hypotension, the total spinal will respond to atropine or glycopyrrolate faster.
Oh,
Okay.
Okay, sir.
Whereas
Yes,
your
sir.
bradycardia, especially with bupivacaine in LAST, will not respond to your conventional vagolytics like atropine or glycopyrrolate. That is the
Yes,
main
sir.
difference. Okay. That is the reason why resuscitation has to be started with the intralipid as early as possible. Okay.
Yes, sir.
So
Yes,
the
sir.
alternative total spinal also has to be thought of, because the
Okay.
catheter could have migrated intravascularly and without blood being seen, which is called negative aspiration for blood can happen, but still the Why? How does negative aspiration occur even when the vessel and the catheter is in the intravascular space?
Sir, if the vessels are collapsed, there might not be aspiration, sir.
The vessels get collapsed when you try
Collapsed.
to
Yes,
apply
sir.
more force to aspirate, the veins may collapse. So in that case, you get a false negative aspiration. And once you inject, because you are increasing the force, it opens the vein and then the drug goes into the vascular system. Similarly, the catheter could migrate into the subarachnoid space, and you may not get a free flow of CSF like you get in a subarachnoid puncture. But drug, once you given with a force, it immediately travels and goes into the intracranial compartment because of the communication, and then produces the total spinal effect. Okay.
Okay.
So
Okay, sir.
total spinal also is one of the
Differential
different
diagnosis.
diagnoses that has to be kept in mind.
Okay, sir.
So we'll just see those things. So this is the 25-year-old trainee develops difficulty. So both will produce difficulty in phonation. So the possibilities for such clinical presentation are total spinal and intravascular injection of the local anesthetic, catheter migration into the subarachnoid space or intravascular with negative aspiration for CSF and blood is the cause for this particular complication. And if it is total spinal, when LA drug ascends into the intracranial compartment, this is the reason for all the clinical tests that you get. And supportive measures like supplemental oxygen, assisting respiration, and reviving hypotension is all needed for total spinal. And control of seizure with benzodiazepam or midazolam can be done. Airway to be secured with endotracheal tube in these cases. And if it is lost due to intravascular injection, early administration of intralipid to be commenced. So how to differentiate total spinal and lost is mainly by the unresponsive bradycardia in LASD to vagolytics, responsive bradycardia to total spinal. So definitely total spinal patients will immediately pick up the heart rate if you give atropine. Whereas LASD patients will not respond to the atropine.
Yes, sir.
And what is lipid shuttle? How does it work? We heard of this terminology. Mentioned
Sir,
about
like
intralipid, the dosage and all those things.
yes,
The
sir.
mechanism of action of lipids. They use a
Yes, sir.
terminology called lipid shuttle.
Lipid sink effect, sir.
Yeah, lipid sink effect is the earlier terminology they were using. So most widely accepted mechanism of lipid emulsion for treatment is called lipid shuttle. Administrative lipid emulsion produces lipid compartments of lipid emulsion, which absorb lipid soluble local anesthetic agents from the brain and the heart because of the increased amount of lipid that is present in the vascular system. By gradient level, it sucks the or removes the bupivacaine which is attached to the lipid molecules in the brain and the heart. So subsequently, lipid emulsion, including the lipid-soluble local anesthetic, is carried to the liver, muscle, and adipose tissue, where it is undergoes detoxification and is stored. Okay? So this is how the cardiac depression produced by the bupivacaine or blockade produced by the bupivacaine is removed, and the heart starts responding to normal supportive measures. Okay? So that is the terminology that is used. Okay. So that is the thing about